going to just do a brief introduction. So welcome everyone to this CWRH OBGYN department seminar slash grand rounds. It is a great pleasure for us to introduce Dr. Jeffrey Smith, who is a Deputy Director of Maternal, Newborn, and Child Health at the Bill and Melinda Gates Foundation in Seattle, Washington. I don't think we need any additional introduction about the Gates Foundation. At the foundation, Dr. Smith leads a portfolio of investments to address the greatest challenges in maternal and newborn health in Africa as well as South Asia. And these investments span the breadth of discovery of new interventions for maternal and newborn health, implementation research on transformative service delivery approaches, and influence in the global health architecture to drive greater collective impact. And we know this from personal and institutional experience because we participate in trials. So just for a brief background, Dr. Smith is an OBGYN and a global health strategist. He has 25 years of clinical and public health experience in developing countries across Asia, Africa, Latin America. His undergraduate and medical degrees were from Georgetown University, and he received public health training from the Johns Hopkins University. He spent 10 years in Asia, where he provided program management and support and technical guidance on a broad range of areas and countries, including Nepal, Afghanistan, and Thailand. And then he's also worked with JAPIGO, which is a well-known, well-established a nonprofit that's affiliated with Johns Hopkins University and does global health work around the reproductive space, and also working with USAID. And so prior to joining the foundation, he was vice president for technical leadership at JAPIGO, where he led a number of initiatives that are relevant to us around reproductive health and infectious diseases. He has authored multiple publications on focusing on areas of importance to us, and holds a faculty position in obstetrics and gynecology at Johns Hopkins University School of Medicine, and the international health in the Johns Hopkins University School of Public Health. So without much ado, really join me in welcoming Dr. Smith. Once again, thank you.
Great. Thank you very much, Alan. It's nice to see you, and I wish I was in Birmingham with you. I wonder if it's possible to ask that the camera be turned on in the conference room at least. We spent so much time at home that sitting and just facing a blank screen without any people there is a bit of a challenge. So I would love it if at least the conference room camera could be turned on so that I could see some people and know that that there is an audience on the other side of the screen. Thanks. So I'll share my screen and we'll jump into this. It's really an honor for me to be joining you all. The work that your team has done in global health and continues to do is really critical, and building. Can you let me know if you can see my screen? Can you see the first slide?
It's great.
Great. Okay. I think one of the things that we've all certainly discovered is that, especially in the pandemic, is that the issues of global health affect all of us. Ill health in one part of the world is ill health in all parts of the world. And I think the responsibility and the collective action to address inequities is something that all of us can be and should be concerned with. And so today I want to really talk about what the foundation is doing, the approach that we take on the maternal, newborn, and child health team, especially driving towards the SDGs, the Sustainable Development Goals in the year 2030. So let's make sure that I can advance. Okay, there we go. So, Alan said that the foundation doesn't need any introduction, but perhaps just a few words on the foundation. I think the foundation was established in 2020 by Bill and Melinda Gates with really a vision to recognizing that where women live and where families live and every woman, every family should have the opportunity to live a healthy, productive life. And all lives have equal value. So where someone lives should not determine if they live. We really can't do anything without our partners. We sit in, as I was saying to Alan at the beginning, we sit in the upper left corner of America on the Pacific Ocean. I'm looking out the window from my apartment and I'm looking at Puget Sound. But we sit in a tiny corner of the planet and we're making decisions and engaging in discussions about changing the lives of women in Africa and Asia. And so it is really with and through our grantees and our partners that we identify these solutions and implement change with the communities that we seek to serve. We're very, very fortunate to have two incredibly generous donors, trustees. Bill and Melinda in July 2021 announced an additional $15 billion commitment to the endowment of the foundation, which really dramatically increases the opportunity that our foundation has to achieve impact across the world. And so the commitment to maternal and newborn health stretches across the foundation in the areas of immunization. We're experiencing an incredibly exciting moment in the global campaign to end polio. There has not been a case of wild polio in the world since January of 2021. We are going on 10 months without a single case of wild polio. The last 2 cases of polio were reported in Pakistan in the end of January and in Afghanistan in the beginning of January. And so, wild polio has been eliminated from Africa, and we really are looking at the potential for eliminating polio from the planet. But the foundation works on immunization, nutrition, a variety of different diseases, but we have a new commitment to gender equality and women's health, and our team on the maternal, newborn, and child health team is at the center of that. The reason we're at the center of it is because maternal and newborn mortality still remains high. It is the health indicator that shows the greatest disparity between developed countries and developing nations. The difference between low and middle income countries and high income countries is really staggering. And the Sustainable Development Goals have set targets for maternal mortality reduction of 70, an MMR of 70 per 100,000 live births by the year 2030, and an NMR of 12. And we hope to achieve those, but we are off track to achieving those, and we really have to accelerate progress. But the challenge of maternal and newborn mortality really sits squarely in the heart of Africa and in South Asia. And so that is where the foundation puts its energy and its focus. But there is a growing understanding that we also need to be working together to address issues of undernutrition among mothers, infants, and children. And some data that I'll share today is really pointing us to the importance of addressing maternal nutrition. And the SDG 2 is really focused on improving nutrition, ending hunger, and addressing the needs of adolescent girls, pregnant and lactating women. And so we'll spend a little bit of time today talking about that as well. The future that the foundation wants to see is a future where healthy mothers deliver healthy babies. And to achieve that, we really need to think differently. I'll talk in a moment about this concept that we really ground our work in called the obstetric transition. But the obstetric transition requires us to think as countries move through different health system scenarios, we really need to be continuing to innovate with them to solve new problems and layering on solutions, because the solutions that solve the problem initially is not going to be the solution that helps us solve the problem in the end. We need to continue to layer on solutions and innovative approaches. And the COVID pandemic has really showed us the importance of strengthening health systems. It is the weakest health systems that suffered the most during COVID, and whenever there are challenges to health. So to focus in on our strategy, I want to cover a few things. First, what is the problem that we're trying to address? It's the fact that while we have made progress in reducing maternal and newborn mortality, progress has slowed. And in fact, COVID-19 has reversed progress in some geographies. And so we really not only need to accelerate, we need to accelerate aggressively in order to address this. But in order to do that, we really need to understand why some mothers and babies are vulnerable, why they're still dying, and how can we specifically design interventions that address the root causes, not just the diseases, but the underlying vulnerabilities that are causing those diseases. And we do that with innovative solutions that I'll discuss, with evidence that not only is global evidence, but evidence that can turn into local practice. Because a global guideline doesn't do a mother in a rural hospital in Malawi or Cameroon any good if we can't translate that into the reality on the ground. But we also recognize at the foundation that although we are blessed with substantial resources, our resources are limited. So how do we effectively partner with countries, to mobilize domestic resources, with international bodies, with the World Health Organization, UN agencies, USAID, the World Bank, in order to drive greater attention and impact? So this is the core of our strategy, the maternal newborn health strategy. We really focus on identifying new innovations, testing those innovations, and bringing them to scale in countries. If you were to look at this from left to right, in Initiative Zero, we're really focusing on understanding the vulnerabilities and why women are dying, women and newborns are dying. Then we use that information in Initiative One with another team at the foundation, which is our partner upstream team that we call the M.P.H Discovery and Tools team. And Alan, you wrote me an email this morning talking about the A+ trial that your team is participating in. And the funding for the A+ trial comes from the NICHD, but it's co-funded by our Discovery and Tools team. And they're the team responsible for the efficacy research, proving the efficacy of certain interventions. And then things come back to the team that I sit on. And in Initiative 2, we're really testing and demonstrating the effectiveness of the packages and the intervention. Do they actually work outside the controlled context of a clinical trial? Can we get azithromycin administered in the intrapartum period for reducing maternal and newborn infection? Can we really get that to fulfill its promise in the health systems where women are dying? The third chevron is recognizing that we have to also look at the health systems themselves. We have to think about the way services are delivered, because many of the health systems are structured in a way that we don't fully access the women and newborns that need the most services. And then in the fourth chevron, we work in country, especially in our principal engagement countries of Nigeria, Ethiopia, and India, to implement interventions and to drive them to scale. And then through the fifth chevron, we work with global levers to really take it to scale across multiple countries throughout Africa and South Asia. So it's really a strategy of make it happen in the beginning to help it happen towards the end of that strategy. And our focus is, as I'll explain, has really shifted a little bit more upstream, and we have much more attention on maternal health, improving maternal nutrition, improving antenatal care and the intrapartum care, and small and sick newborn care, as opposed to a big focus on child health. The other parts of the foundation are focused on child health in a variety of ways, but our team really says that if we help women have healthy pregnancies and healthy babies, those babies are able to withstand that first dose or that first bout of diarrhea or pneumonia. But if women who are malnourished and receive poor care deliver babies who are weak and vulnerable, those weak and vulnerable babies are more likely to succumb to that first bout of diarrhea or pneumonia. So our strategy was approved in 2018, and it really was a substantial shift, as I mentioned. And there are 5 domains of the shift that I'll get into. The first is that, as I have said already, we're really focusing on not necessarily all mothers and babies, but the more vulnerable. And I want to talk a bit about, give an example of looking at maternal anemia and the use of a novel approach called intravenous iron. And then we really shifted towards the development and testing of tools, technologies, innovations that we consider global public goods that can target these vulnerabilities. And I'll talk a bit about a story that I'm sure many of you are familiar with, the issue of antenatal corticosteroids and the challenge that that intervention takes. We also have moved very much from retail approaches to wholesale. And what I mean by that is, instead of doing PDSA quality improvement cycles in facility after facility after facility, are there things that are more structural in the health system that we can do that address the fundamental functioning of the health system that can improve all facilities and the way the entire health system works? And I want to talk a bit about a concept that's really taking off called networks of care and something called service delivery redesign. And then growth and resilience, and we'll talk a bit more about maternal nutrition, because I would specifically love your feedback on how we think more about the understanding of the maternal health community in improving nutrition. And then I'll talk about the foundation's role in coordinating with global partners. As I mentioned before, we really anchor a lot of our work on this concept of the obstetric transition, which is undergoing a revision now by WHO to be considered more the obstetric and newborn transition. It is really saying that the strategies and the interventions that are useful in a country where maternal mortality is about 1,000 or newborn mortality is 45 or 50, the interventions in that kind of an environment are very different than the interventions in a country where maternal mortality is 500 or 200 or 100. And though as countries move through that transition from high mortality to lower mortality, we need to be able to support them to add on interventions and add on strategies to help drive that reduction. If we look at the graph, it shows that maternal mortality fell over the last 20 or 30 years, but it fell at very different rates in countries that are in different parts of the obstetric transition and newborn transition. It falls faster for the countries that start with higher mortality, but we have to figure out how to help it continue to fall even in low mortality environments. But it's not the same but each country can't be considered one monolith. India, Nigeria are huge countries, highly variable, and mortality in different parts of India and Nigeria are going to need specific interventions and approaches. So one of the things that we have really started to focus on is the question of maternal anemia. There is a World Health target on addressing anemia and reducing anemia. And anemia is an issue that falls heavily on pregnant women and children, and there are more than 32 million women in the world who are anemic during pregnancy. And that burden falls predominantly in West and Central Africa and in South Asia. And so the approach that we take is a multi-tiered approach using a variety of different interventions from the foundation. At the base of the pyramid, and maybe even below the base of this pyramid, are things like improved reproductive health, the availability of family planning, the improvement in water and sanitation and gender. But at the base of this pyramid, we look at food fortification. How can we get iron into the food system so that that's an intervention available to the entire population. But then for pregnant and lactating women, the provision of iron supplementation, either through IFA, iron folic acid, as currently done, or in many countries, the transition to MMS, which is multiple micronutrient supplements, and the addition of balanced energy protein with iron. But then there are still going to be a certain percentage of women with moderate to severe anemia that for which oral supplementation is not enough. What can we do in the development and optimization of intravenous iron products to target those women? How can we use new devices, such as a point of care device, to measure hemoglobin non-invasively, where I would like to see hemoglobin measurement become the 5th vital sign, that when a woman comes in for her antenatal visit, she gets her blood pressure, her temperature, etc. taken, but she also gets a probe put on her finger that measures her hemoglobin non-invasively, and that tool exists. And so we're optimizing that so that we can identify the women with moderate to severe anemia and then target them with intravenous iron. We have 3 trials going on, or 4 trials going on right now in Nigeria, Bangladesh, and Malawi that are looking at the provision of iron, comparing oral iron to intravenous iron for addressing severe anemia during pregnancy. And then we're starting some new trials looking at postpartum administration of IV iron for women who remain anemic or who've suffered from postpartum hemorrhage. Another area that we've focused on is the issue of antenatal steroids. And this is something that all of you who practice clinically will be very much familiar with. When we look at the distribution of child deaths, we know that newborn mortality remains the #1 cause of, or the #1 domain of where children are dying. But it is preterm birth that is the #1 cause of both newborn mortality and under 5 mortality. And within that, it's respiratory distress that is the greatest contributor to newborn mortality. And there was a very important paper, and I don't know, Alan, if you participated in the ACT trial, but it was a very interesting study conducted by the NICHD that looked at if we think antenatal steroids are useful, why can't we increase the provision of it to a wider group and wider population? And unfortunately, the ACT trial demonstrated that wide distribution of antenatal corticosteroids actually increased newborn mortality. And it was a very puzzling outcome that really caused a lot of consternation in the global maternal newborn health community. And so the foundation funded a more definitive trial on the use of dexamethasone for women at imminent risk of preterm birth. And very happily, when the Action 1 trial was published last year, it demonstrated efficacy of dexamethasone given to pregnant women for the reduction of mortality among preterm newborns. This has resulted in the WHO preparing to update its recommendation and fine-tune its recommendation on the use of antenatal steroids. But now it's incumbent upon all of us to work on implementation. How do we take the ideas, the efficacy research, and turn it into action at the country level so that we can work with health systems in order to implement the use of antenatal steroids. The next few slides that I want to cover are covering these two ideas that I mentioned earlier about not only designing really great interventions, new drugs, new products, new interventions, but we have to also think through the health systems and the service delivery systems into which those interventions are introduced. And currently, the service delivery systems are challenged in their capacity to deliver even the most effective and impactful intervention. So this concept of networks of care is something that I think you all are at the center of. I'm quite certain, when I was practicing clinically at Johns Hopkins, we were the center of the Maryland Perinatal Network. And women out on the Eastern Shore or in different parts of Maryland that developed antenatal or intrapartum complications were often medevaced into Johns Hopkins Hospital for further treatment. I'm quite sure that the University of Alabama at Birmingham is the center of the Alabama and maybe beyond perinatal network. And so you understand this concept of networks of care extremely well. And the two words that we were taught to say when that phone rang at 3 a.m. with an incoming transport, the first two words out of your mouth are thank you. Thank you for calling. Thank you for sending your patient. We will absolutely accept the transport. We will take care of your patient and we'll call you in the morning and tell you how she's doing. That is not necessarily the dimension of care that exists between facilities in the countries where we work. So we commissioned a review of the concept of networks of care that was published last year. And it's really quite remarkable because it is an idea that is catching on. WHO has really taken this up as an idea that it is exploring as a new health systems. I say new, but to you, all of you, you would say that's not new. There's nothing new about that. But in places like Kenya and India and such, it is a new concept. And the reason that it's a new concept is there was a trial that was done in Uttar Pradesh, northern India, that called the Better Birth Trial, and done by a fantastic, well-known, famous investigator, Atul Gawande from Harvard. And the Better Birth Trial said, if we improve the care using safe childbirth checklists and strengthen the quality of care within facilities, we definitely will see a reduction in maternal and newborn mortality. And the Better Birth Trial showed absolutely no reduction in maternal and newborn mortality, even though they were able to improve care. They were able to improve care according to the Safe Childbirth Checklist, but what they found was the connection between facilities within the health system was so weak that there was no network, that if a woman came to a facility and that facility said, ma'am, we don't have the capacity to help you and manage your complication here, you need to go up the road. You need to find another place where they can take care of you better. That breakdown of the system and of the network resulted in no impact. And so when we think about networks, there are steps, there are concrete steps that can and must be taken to build these networks, build the trust between the nodes of the network, and strengthen the concept of geographic management rather than simple in-hospital management. So, and it's interesting because right now the government of Ghana, the health system in Ghana, is about to launch a new $200 million World Bank grant and loan to establish networks of practice across the entire health system of Ghana. So people are starting to take to realize that we can't just work within individual facilities. We've got to look at the system of connection between all of those facilities as well. Another new idea is something that is shocking at first, but I'm going to show you a slide in a few minutes that show that it is something that we're all having to deal with. As countries move through the obstetric transition, we have to help think about ways to structure the health system and approaches for providing care that perhaps are not necessarily designing for access, but designing for survival and designing for impact. Right now, health systems are designed to allow health centers as close to the woman, as close to the village as possible, but those health centers may not actually be able to offer the care that women need. If you look at this slide, the SDG target for maternal mortality reduction is 70. All of these facilities have achieved facility birth rates greater than 80%. So every one of these countries, more than 80% of women are delivering in facilities, but they have widely varied maternal mortality. In DR Congo, the maternal mortality, they've got more than 90% facility birth rate, but they still have an MMR approaching 700. Same thing is true with newborn mortality. You've got places where huge numbers of babies are born in facilities, but mortality is varied, widely varied throughout that. And these groupings are related to socioeconomic development. And so you've got some countries that are low income countries that have high mortalities, and some middle income countries that have low mortality and some that have high. And part of it is because there's actually a bit of a weak association between coverage and survival. And this could be because all facilities are not designed the same. All facilities are not equal. If you look at this collection of data, there has been a movement away from home birth and towards facility birth, but still large numbers of births happen in lower levels of the health system, in primary health centers. And the strategy has been access. It's been delivery in basic emergency obstetric care units that have the capacity to provide a minimum set of basic interventions. But we're not necessarily sure that that's the distribution of birth between hospitals and primary health centers is necessarily getting us the reduction in mortality that we need. If we look at this data across 5 countries in Africa, and on the y-axis, quality of care in these facilities, and on the x-axis, volume of deliveries. So you have the blue X's are primary care facilities, PHCs, which generally have much lower volume and much lower quality. But the red circles are secondary care facilities, district hospitals and such. And they tend to have overall higher quality of care and overall greater volume. And that just kind of makes sense. If you think about facilities that do 5 or 10 deliveries a month, that midwife in that facility is going to see what, 60, 100 deliveries in a year. Her exposure to a postpartum hemorrhage is going to come a couple times a year. Her exposure to an eclamptic seizure is going to come once every couple of years. It's a lot to expect her to remember how to manage that eclamptic seizure or that newborn resuscitation if she only sees it once every 6 months or 8 months. So what are the strategies that have been considered for dealing with this low quality, this perceived low quality in primary health centers? Well, there's the idea of we'll work to improve the quality in these primary health centers. And there have been huge efforts to improve quality, do training of the midwives, improve the quality in these PHCs. I'll talk about that in a second. The second is strengthening risk assessment so we can know, okay, who should go into these primary health centers and who should go into hospitals. And that's fraught with challenges. And the third is to improve transfer capacity. So let's look at the Better Birth Study again. The Better Birth Study really said, we're going to improve quality in these PHCs by using the Safe Childbirth Checklist. And guess what? They did. Using the Safe Childbirth Checklist, they were able to improve quality measured on the checklist in many different primary health facilities, but it didn't reduce mortality. And it was because there's only so much that those primary healthcare facilities can manage. And it's the connection between facilities that really makes a difference. The authors, Catherine Sumrall, who's the author of this paper at Harvard and Ariadne Labs that carried out this study, said it is the issue of systemness, systems for connecting these different facilities that really makes the difference. So just improving care in individual facilities, especially primary health facilities, is not going to reduce mortality. The second is the idea of risk stratification. It's an idea that students of maternal newborn health know that this was tried back in the 80s and 70s. And there were the risk factors, and women, if you had a risk factor, you delivered in a hospital. And if you didn't have a risk factor, you could deliver at home with the TBA. The reality is that postpartum complications, postpartum hemorrhage, eclampsia, newborn asphyxia happened as much in women who had complications as didn't. And this shows that even in the US, 40% of women are considered low risk, but they still have substantial risk of complication. And we don't ask women in the US to deliver in their doctor's offices or in their midwives' offices. We recommend that women deliver in hospitals. And then the third strategy is let's improve the referral system. Well, when you look across 10 different low and middle income countries at thousands of primary health centers, it's really a minority of them that have a functional ambulance at the ready with fuel able to transport a woman. And so transport systems are really poorly functional, and communication systems are poorly functional. They're getting better, and we need to recognize that they're getting better. That's why investment in roads, investment in infrastructure, investment in telecommunications, and mobile phone penetration is really critical. But if all of these strategies are not sufficient, then maybe we need to think about redesigning the system, and redesigning to maximize survival, not just maximizing access. So we're implementing with partners from the government of Kenya, the government of Kakamega County, Harvard, Jacaranda, and others, a look at redistributing and redesigning how services are provided in Kakamega County in Kenya. It's a county with about 2 million people, 70,000 deliveries a year, with still high maternal mortality and high newborn mortality. About a third of deliveries occur at home, at hospital, and at primary health care. So the idea is to say, let's increase the number of births in facilities, but drive those facilities to hospitals and facilities near hospitals that have the capacity to immediately resolve maternal and newborn complications. And if you think, and so let's just think about the 205 facilities in Kakamega County that are delivery facilities. 9 of them have high volume, greater than 90 deliveries per month. But the majority of them, the vast majority of them, do less than 30 deliveries a month. What is that? Almost 160, 170 out of the 205 facilities do less than 30 deliveries a month. And this results in having to staff and equip and supply and get drugs to hundreds and hundreds of facilities that only do a few deliveries a month. And that's just not an efficient and effective way of structuring the health system. And if you look at the competence and the confidence of providers in those facilities, in the yellow bar are clinical officers and nurses in the lower level facilities, and they express very poor competence and confidence in being able to manage preeclampsia, hemorrhage, obstructed labor, etc. It's doctors and it's nurses in higher level facilities that have much greater confidence and competence. Same thing is, yeah, competence and confidence, these two slides. So if you think this is a radical idea that a bald old white guy from the upper left corner of America is imposing on Kakamega County, the reality is that you're doing it in Alabama as well. In the last, 20, 30 years, Alabama has concentrated its births in higher volume, higher expertise facilities. And that is a challenge. This is not a strategy without its challenges, but it's a strategy that reflects where the best possible care can be provided to women and recognizes that you cannot necessarily provide competent expert care in every corner of your geography. So in Kakamega County, 99% of women live within 1 hour travel distance, not as the crow flies distance, but travel distance from one of 16 facilities. And the idea is over the next 5 years to concentrate births in those 16 facilities, at or near those 16 facilities. So this is about strengthening the capacity of the hospitals, improving primary care to do what it can do best, improving demand, but also improving access. And I think the last thing I want you to believe is that the idea is about driving all women into overcrowded, chaotic, poor quality hospitals. I think a lot of the solution can come from an on-site or near-site midwife-led birthing center where women can get high quality care from competent midwives who have the access to comprehensive, definitive care across the parking lot or within the same campus of the facility, or the ability to go 5 blocks away from where the birthing center is to where the hospital is. So this is an idea that has to be tested. You all are testing it in Alabama, whether you know it or not, and we need to think and work with partners in and around high volume or counties and districts in different parts of the world to see if this works. So that's an idea that I think is one of those disruptive ideas that the foundation is pursuing. I have a few more slides and then I want to open it up to questions. So another domain that we're really focusing on is the issue of maternal nutrition. Poor maternal nutrition is a huge and underappreciated driver of maternal and newborn complication, morbidity, and mortality. And I think when I think about our role as maternal health providers, obstetricians, primary care providers, midwives, we spend we do a very poor job of addressing maternal nutrition during pregnancy. We tend to tell women, take a vitamin, yeah, anyone is good, and yeah, get a balanced diet, but we don't really focus on critical issues in maternal and newborn, maternal nutrition that can really impact both maternal health and newborn health. This is a distribution of mortality and the contribution of undernutrition to causes of maternal death and newborn death. Maternal deaths in Pakistan, India, and Bangladesh, and Nigeria, Burkina Faso, and Ethiopia. And there's an enormous contribution of undernutrition to a variety of causes of maternal mortality. If you think about it, a woman who has moderate to severe anemia is 6 to 9 times more likely to have a postpartum hemorrhage than a woman who has no anemia. The uterus is a muscle. If you can't deliver adequate oxygen to that muscle, it's not going to contract very well. And so the contribution of anemia to postpartum hemorrhage is not as appreciated as much as the contribution of hemorrhage to anemia. And so that's something that we need to change. The last thing is the work that we've done on working to address coordination of the global architecture. I have been extremely frustrated in my career to see the maternal health community and the newborn health community kind of isolated from each other. And I have to agree that the foundation was part of the problem. For many years, there was an investment called Saving Newborn Lives. And there was a separate investment called the Maternal Health Task Force. And those worked on maternal and newborn health separately. And we really need to work now to align the maternal and unite the maternal and newborn communities. Look right now, right this week, the global obstetricians are gathered online for the FIGO conference. Well, who attends the FIGO conference? It's the obstetricians. Who attends the midwife conference? It's the midwives. Who attends the health system research conference? It's the health system people. Maternal newborn health doesn't actually have a conference that brings the communities together. The last global maternal newborn health conference, the one and only global maternal newborn health conference, was held in Mexico City in 2015. It's been 6 years since we've brought the newborn health community together. So the Align M.P.H initiative is something that the foundation and USAID are working on together. And the intention is to organize and curate global knowledge assets in maternal newborn health, proactively make those assets available to ministries of health, to technical working groups. When Dr. Tita said in my introduction, I spent many years in Asia, and I spent 3.5 years in Afghanistan, and every Tuesday or every one Tuesday a month, I would go to the ministry for the Safe Motherhood Working Group, the Maternal Newborn Health Technical Working Group. And the agenda was chaotic. It was who's got a topic to bring up, who's doing this, who's doing that. And there wasn't real access to global information that was made available to the Ministry of Health to drive policy decisions. And then the third objective of Align M.P.H is to organize, as the Secretariat, a regular, every 2 years, International Maternal Newborn Health Conference that will take place in April 2021? No. April 2022? No. Hopefully April 2023 in Cape Town, South Africa will be the first of this series of biannual conferences to address global maternal newborn health and bring the community together. So I went through dimensions of the BMGF maternal newborn health strategy and how we've made some strategic shifts over the last few years. And I hope I provided some examples of how we actually execute on that. But I also want to talk to you about how do you in Birmingham, Alabama, get engaged in global women's health and make a difference. You're doing incredible things. You have the capacity to do even more. I love that you are renaming your center and focusing on a more global engagement. I would say be focused on the critical things. Everybody can't do everything, and so what value add, what specific additional value do you all bring to the community and to the endeavor? Understand how to add value, build relationships. I still have relationships with young people when I was younger and young investigators that I met in some of the countries where I worked, and we have known each other over 20 years, and those relationships have developed and been beneficial on both sides. Be consistent. While it's interesting to visit Kenya this year and Malawi next year and Cameroon the following year, having a consistent relationship and dedication to a few institutions is better than having many stamps in your passport. Those relationships are what drives, for better or for worse, that drives a change in our field. But we also have to understand and account for power dynamics and the power that is inherent in the foundation, in the group that's of people coming from the United States, and how do we share ownership of the vision with our partners? And how do we put more and more of the decision-making in the hands of our partners? So I talked longer than I wanted. I will turn it back over to you all now. And I hope this stimulated some opportunity for questions. And a big thank you to Rachel Sinke for having her camera on, because she and Alan were the only people I could see whether or not the messages were landing. So thank you very much.
Thank you, Jeff. And there were a few more, I think there were a few more, and those sitting in the conference room also had their camera on. So
great, it was hard for me to see from using two screens.
It's open for questions.
Please, and I want to stop sharing my screen, and great. There's the conference room. Now I can see the conference room. That's one of the problems with Zoom is.
Yeah.
Ashley and Sharon, thank you very much. I can see you now. Okay, given that WHO in 2021 has stated that there is a shortage of midwives, excellent. I completely agree. There is an enormous shortage of midwives. What is the rest of the question? Incorporate in-hospital midwives near given Alabama's few certified nurse midwives in a very limited situation. There's been work facilitating new networks. So I'm not sure what you mean by new networks. I think midwifery is an absolutely critical part of any solution set for maternal and newborn health. I think we need to dramatically increase the number of midwives, the scope of practice of midwives, the role of midwives, because we know that midwives can make an enormous difference. I was in a country that I won't name recently that is working on strengthening its midwifery cadre, and we had some discussions with the leadership of a hospital that was looking at being a training facility for midwives, and a group of very well-meaning but ill-guided obstetricians said, yes, send the midwives here. I'll teach them. I'll tell them exactly what they can do and they can't do. That is not the strategy for empowering midwives at all.
Thank you, Jeff, for that question. Yeah.
If people want to, feel free to voice their questions. That would be good as well. Can you share any work Gates is currently doing around social interventions to address women's health? For example, social cash transfers, use of maternity waiting homes to improve. Yeah, great. So we have a whole unit within the foundation, which is called Financial Services for the Poor. And they are working on improving women's inclusion in financial systems. Melinda announced at the Gender Equality Forum in Paris earlier this year an additional $1 billion of investment into gender. And we've taken the entire foundation is now taking a gender lens to every single one of our investments. So we look at any investment and we make a determination, is it gender unintentional, gender intentional, or gender transformative? And what can we do to move an investment along that continuum of being more gender transformative? So we're quite dedicated to addressing that. One of the other parts of we brought the maternal, infant, young child nutrition, the MIYCN team, we actually moved them from the nutrition team into the MNCH team about a year and a half ago. And the intention was because, to a great extent, they are using the maternal newborn health platforms such as antenatal care, postnatal care, to deliver nutrition interventions, but not exclusively. And so we have a lot of interventions looking at conditional cash transfers, using social protection systems and other systems for providing nutrition support.
So Jeff, let me take one or two, ask one or two. So the global network and Wally Carlo, who is the neonatologist here, as part of that, did participate in the ACT trial that initially suggested that steroids were a bad thing. Can you comment on why there was a difference between that study and the later study that WHO did?
Yeah. So preterm birth is an enormously difficult thing to measure in low and middle income countries, because just preterm birth, really, first you have to say, is it preterm? Is this, what was the gestational age? Did the woman get an early ultrasound? And do we know that this is actually a preterm newborn and not a small for gestational age newborn? And I think, unfortunately, in the ACT trial, they used birth weight as a proxy for preterm. And so women who presented with suggestion of labor, who were assumed by the provider to be less than 37 weeks, were assumed to be preterm and were given antenatal steroids. The vast majority of those women ended up not delivering, and the vast majority of those who did deliver small babies did not have access to the intervention. So the ACT trial was entirely well-intentioned to say, antenatal steroids looks great, let's increase coverage. But unfortunately, it looks like the intervention was given too much to the wrong population and not enough to the right population, and the actual population was not completely determined. The ACTION trial, implemented by WHO and published last year, set forward a much more rigid approach to assessment of gestational age, determination of who was preterm, clarifying whether or not women were actually at risk of preterm birth, not just came in with a few preterm contractions. And then are they so far along in their preterm labor that they're going to deliver in the next few hours, and administration of a dose of antenatal steroids is not going to have a benefit anyway. And then also the critical issue of being able to care for the preterm newborn. So all of those dimensions of better diagnosis, better gestational age assessment, and better care after birth were built into the ACTION trial, and they were not necessarily built as strongly into the ACT trial. Now it's my team's job, with our implementation research agenda, to say, can we take those criteria of better gestational age assessment, better clinical care, and postnatal care to newborns, can we actually put that into practice in countries? And so we have an investment that's just getting started that's going to, on a massive scale, look at implementation of these recommendations in Pakistan, Bangladesh, Nigeria, and Ethiopia.
No, thank you. That's fantastic to bring that, to us. It's right. We use this every day, but it's, amazing that it's just now it's getting to some of these places. A quick two-part question, just briefly, for those on the here who are thinking, I'm thinking about the residents, the fellows who are thinking, okay, how do I get into global health work? How do I fund, my global health engagement, and even faculty members? Can you provide some suggestions? And then on the other hand, how do the investigators here engage with the foundation to, work on meaningful projects?
Yeah, that's great. So I had my first opportunity when I was a medical student. I went with one of my professors to Rwanda to look at global health, a global health project, and it really sparked an interest in me. So hopefully medical students, if they're in the mix here, it's not too early. But I think, as I said, it's important to develop some relationships and build consistency. You are far more likely to get a research trial funded or some grant application funded if you can demonstrate commitment to an institution over time. If you're not a co-applicant with your partner in that facility or that institution in a low and middle income country, the likelihood of grant success is extremely low. And I think more and more people are looking, I know our foundation is not just looking at, oh, how nice, the investigators identified 3 hospitals to work with in Tanzania, but the application is being submitted together with Ifakara Institute in Tanzania, Research Institute on Maternal Newborn Health, and the University of Alabama. If you just submit it as the University of Alabama without a strong partnership with an LMIC institution, it's going to be viewed far less favorably. The foundation does a mixture of both open calls for proposals and more targeted requests for program development. And a lot of our focus, as I mentioned, is more and more to the in-country partners. So we are really trying our best to practice this concept of decolonization of global health by putting more of the decision-making and the thinking in the hands of the institutions from the countries of concern, and not having the decisions made by northern institutions. It's a hard process, but it's one that we're really trying to dedicate ourselves to.
All right. Well, thank you so much, Dr. Smith. Jeff, again, we appreciate you taking time to talk to us, and I think that's it. Thank you, and talk soon.
Thanks very much, and I really appreciate the honor of the invitation.
All right.
Take care.
Bye-bye.
Bye-bye.